بسم الله الرحمن الرحيم. أعزائي طلبة المرحلة الخامسة، نرحب بكم من جديد. We'll talk today in series of pediatric renal disease. This lecture is divided in two lectures really. It's about renal failure. We start firstly about acute renal failure, defined as clinical syndrome in which a sudden deterioration of renal function result of inability of kidney to maintain fluid and electrolyte hemostasis. This is the main function of the kidney. We can classify acute renal failure according to the RIFLE classification. This RIFLE is contained of 5 letters. First, R mean risk. There will be an increase in serum creatinine level more than 1.5 or decrease in the GFR, glomerular filtration rate, by 25%, or urine output less than 0.5 ml per kg per hour for 6 hours. This is R. For I, injury, there is an increase in the serum creatinine level multiplied by 2 or decrease GFR up to 50% and urine output less than 0.5 ml per kg per hour for 12 hours. For F, mean failure, there is increased serum creatinine level more than 3 multiplied by 3, decrease GFR to 75%, serum creatinine level more than or equal to 4 mg per deciliter, urine output less than 0.3 ml per kg per hour for 24 hours, or anuria for 12 hours. Loss, persistent of acute renal failure with complete loss of kidney function for more than 4 weeks, end-stage renal failure, loss of kidney function more than 3 months. This is a RIFLE classification of acute renal failure. What about pathophysiology of acute renal failure? The driving force, before we go to the pathophysiology, must be remind us the physiology of renal function and kidney. The driving force for glomerular filtration is the pressure gradient from glomerulus to the Bowman space. The glomerular pressure is primarily dependent on the renal blood flow, RPF, and is controlled by combined resistance of renal efferent and efferent arteriole. So regardless the cause of acute renal failure, reduction in the renal blood flow represents the common pathology pathway for decreasing the GFR. The etiology of acute renal failure can be classified into 3 mechanisms. Firstly, either pre-renal or renal or post-renal. Pre-renal failure is caused by decrease of circulating arterial volume. There will be hypovolemia, mean inadequate renal perfusion, will be decreased the glomerular filtration and lead to the, but there is no primary kidney injury. About intrinsic or renal failure, include there will be decrease in the kidney itself, disease of the kidney itself, affecting the glomerulus or tubule, and associated with release of renal efferent vasoconstrictors. Ischemic renal injury is the most common cause of intrinsic renal failure. The third causes of renal failure here, post-obstructive or what we call post-renal, caused by increase in the tubular pressure, decrease in filtration driving force. So decrease in the renal blood flow lead to the ischemia and cell death. Initially, the ischemia insult trigger a cascade of the event, which is production of oxygen free radicals, cytokines, enzyme, endothelial activation, and activation of coagulation. The tubular cell damage results in the disruption of the tight junction between cells, allow back leak of the glomerular filtrate, and further decrease of effective GFR. Dying cell sloughing off into the tubule, forming an obstructive cast, and there will be decrease in the GFR. So cellular damage leads a tight junction as well as sloughing. All these decrease the GFR. When there is recovery of acute renal failure, it is depend on the restoration of renal blood flow. If there is a pre-renal cause of renal failure, restoration of circulating blood volume is usually sufficient to relieve of the acute renal failure. Rapid relief of urinary obstruction, if it is post renal cause, result in the prompt decrease of vasoconstriction, while intrinsic renal failure, removal of tubular toxins, and initiation of therapy for glomerular disease will be decreased renal afferent vasoconstrictor, which is the main cause of the sequences of renal failure, of the intrinsic type of renal failure. So we talk generally on the causes, but the common causes of each type of renal failure. For pre-renal, as we say, it is hypovolemia. So we talk about dehydration, hemorrhage, sepsis, hypovolemia, and cardiac failure. For renal, any glomerular nephritis, whatever the type, may cause renal failure. HUS, acute tubular necrosis, renal vein thrombosis, rhabdomyolysis, and we talked previously about that. Acute intestinal nephritis, tumor infiltration, and tumor lysis syndrome. For post-renal, any obstruction like posterior tubular valve, utero-pelvic junction obstruction, uterovesical junction, tumor, urolithiasis, hemorrhagic cystitis, and urological bladder, and there is a list of causes really. What about tumor lysis syndrome? Is one of the life-threatened condition and one of the specific form of acute renal failure related to the spontaneous or chemotherapy-induced cell lysis in patients with a lymphoproliferative malignancy. This causes CAS and obstruction of tubules by uric acid crystal. There is hyperuricemia, hyperkalemia, and it is one of the medical emergencies. What about clinical feature? We start from history. If we see infant with history of acute gastroenteritis, dehydration, we talk about pre-renal renal failure. If the patient 6-year-old child with recent pharyngitis or presented with periorbital edema, hypertension, we talk about post-streptococcal glomerulonephritis, so intrinsic type of acute renal failure. A neonate with history of hydronephrosis on perinatal ultrasound, palpable bladder, most likely it is congenital urinary tract obstruction and mostly posterior urethral valve, especially in the male. The presence of rash, arthritis, suggests SLE or hemolytic uremic syndrome or Henoch-Schönlein-Barber. Palpable flank mass may suggest renal vein thrombosis or tumor, cystic disease, or urinary tract obstruction. If we send the urine analysis as part of diagnosis, normal urinary sediment without hemoglobin, or protein, cell, or CAS, it consists with the pre-renal and post-renal failure. Meaning there is no primary effect of the kidney. There is a granular CAS, glomerulonephritis, and interstitial nephritis. You consider RBC CAS, meaning glomerulonephritis. White piece CAS may be pyelonephritis. Blood urea nitrogen is usually elevated, but it correlates poorly with a GFR. Serum creatinine measurement provides an accurate and constant estimation of GFR. Change in the serum creatinine level reflects the change in the GFR. Let me see this equation. If creatinine 1 mg per deciliter is a baseline for given patient with a normal GFR, so creatinine 2 means there is a 50% reduction of the GFR. If 3 to 4 means 70 to 85% reduction of GFR, and creatinine 8 means 90 to 95% reduction of GFR. This is a crude and general idea about the GFR. What about cystatin C? Cystatin C is a substance that cannot be secreted or metabolized from the kidney. So it is a superior biomarker for early kidney injury. It is generated at constant rate by all nucleated cells, not secreted by tubules or eliminated by other routes other than renal excretion. So it does not appear to be affected by body habits or nutritional status or comorbid disease. One of its principal advantages can be identified kidney injury, while the creatinine level remain in the normal range. This is from early kidney injury. If we send the CBC, we'll see anemia due to mostly dilutional or hemolytic, as in the SLE, or renal vein thrombosis and HUS. Or we'll see leukopenia, especially in SLE, thrombocytopenia in SLE, and renal vein thrombosis and HUS. For blood biochemistry, we'll see hypocalcemia, it's moderate, the common acute renal failure due to the increased phosphate level. Hyperkalemia is the common and important complication, one of the emergencies complication of acute renal failure. Or there will be metabolic acidosis, and if we send the C3 we are searching for the primary cause of the renal failure. If it is decreased, meaning a post-streptococcal glomerulonephritis or SLE, antibody detecting the serum for streptococcal like ASO titer, or antinuclear antibody for SLE. For imaging study as part of the diagnosis, chest X-ray may show cardiomegaly, pulmonary congestion, renal ultrasound can be detected hydronephrosis or other primary disease. Doppler and assess the renal perfusion, allow for the large vessel etiology. ECG is mandatory for looking for the manifestation of hyperkalemia or hypocalcemia and arrhythmia. Renal biopsies is helpful to find the specific cause of intrinsic renal failure, but is not routinely management of acute renal failure. It is important when glomerular causes of acute renal failure are suspected. And this is a table for urine indices distinguish between renal and intrinsic acute renal failure for a specific gravity, urine osmolarity, urine sodium, fractionated sodium, blood urea, nitrogen, and creatinine, and you see the difference between each of them and can give idea about the causes of acute from the chronic renal failure. I will stop here and will complete in the next lecture.